Good afternoon. This is Dr. Roz Platzker, and welcome to the STD Expert Hour webinar series. Today, we will be going over disseminated gonococcal infection, presented by Dr. Laura Quilter of the Centers for Disease Control and Prevention, and Dr. Eric Tang, Public Health Medical Officer of the STD Control Branch of the California Department of Public Health. We'll give it a minute or two more before we get going. Hello again, this is Dr. Rosalind Platzker from the California Prevention Training Center. Welcome to the STD Expert Hour webinar series. Today we will discuss disseminated gonococcal infection presented by Drs. Laura Quilter of the Centers for Disease Control and Prevention and Dr. Eric Tang, Public Health Medical Officer from the STD Control Branch of the California Department of Public Health. We'll give it one more minute and then we'll get started. Okay, hello everybody, and one final welcome to the STD Expert Hour webinar series presented by the California Prevention Training Center. I'm Dr. Rosalind Platzker of the California Prevention Training Center, and today we will discuss disseminated gonococcal infection presented by Laura Quilter of the Centers for Disease Control and Prevention and Eric Tang, Public Health Medical Officer of the STD Control Branch of the California Department of Public Health. And we will get started. So first, I'd like to introduce Dr. Laura Quilter. Dr. Laura Quilter is a medical epidemiologist on the clinical team within the Division of STD Prevention at the Centers for Disease Control and Prevention, or the CDC. She joined CDC and the US Public Health Service as an Epidemic Intelligence Service Officer within the Division of STD Prevention in 2017. Prior to her arrival at CDC, Lieutenant Quilter completed her Infectious Diseases Fellowship and received her Master's of Public Health in Global Health at the University of Washington and completed her Internal Medicine residency at the University of Pittsburgh Medical Center. Lieutenant Quilter's interests have focused on public health and STD prevention, with prior interest experience involving extragenital gonococcal and chlamydial infections, neurosyphilis, and the surveillance of antimicrobial resistance in Neisseria gonorrhea. Dr. Eric Tang is part of the clinical faculty here at the California Prevention Training Center and is a public health medical officer for the STD Control Branch at the California Department of Public Health. Dr. Tang received his medical degree at Columbia University, College of Physicians and Surgeons, and his Master's of Public Health at the University of California, Berkeley. He is double boarded in internal medicine and preventive medicine and completed his residency at Kaiser San Francisco and University of California, San Francisco. He currently sees patients at City Clinic, the municipal STD clinic in San Francisco. A little bit about the California Prevention Training Center. We are a multidisciplinary training and capacity building assistance center. This is our logo, CAPTC, and we are funded by the Centers for Disease Control and Prevention, which is part of the National Network of STD Clinical Prevention Training Centers, or NNPTC. We represent the Western region, including California, Nevada, New Mexico, Arizona, and Hawaii, and we are one of 8 training centers across the country. We participate in an STD clinical consultation network. If any of you ever have complex questions about STDs regarding patient care, you can reach us at stdccn.org and we will respond within 1 to 5 days via email or phone, whichever you prefer. This is a financial disclosure. And for continuing medical education, you need to be registered for the webinar on NNPTC and attend this live webinar, which you are. Thank you very much. After that, you need to complete a post-course survey evaluation, and that will be in your email inbox. Make sure that you have cme@med.unr.edu as a trusted email, and that will give you the post-course evaluation survey. You will complete that by March 2nd, and then CME certificates will be available within 6 to 8 weeks. So please allow approximately 6 to 8 weeks processing time from the post-course survey evaluation. A couple housekeeping things. The attendee speaker during the webinar. So your microphones will be turned off. Your video will also be turned off during the webinar, as will chat. If you have questions for the panelists, please submit them via the Q&A, which will be turned on during the webinar. And then at the end of the webinar, we will address questions. And you can see the Q&A icon from the Zoom panel. It looks like this little box here with 2 chat bubbles. So you click on that icon to open the chat window, and then you type your question and click send. The host will answer any administrative questions, and you can enter those in the Q&A chat as well. And as I mentioned, panelists will enter questions on the presentation content in the either in the chat window if it's something that's relatively specific and short, or during the Q&A section at the end of this talk. If you have any questions about this webinar, after the webinar, or any questions about the California Prevention Training Center in general and our services, please email Elizabeth Olson, our wonderful clinical program manager. Her email address is here, elizabeth.olson@ucsf.edu. And with that, I will hand it over to Dr. Quilter. Thank you very much for coming.
Thank you, Dr. Plotzker. I'm just pulling up my slides here. There we go. So good afternoon. So during this session today, we'll start with a case study, and then we'll briefly review the gonorrhea epidemic in the United States for historical context before I provide an overview of disseminated gonococcal infection, or DGI. We'll also discuss the Michigan DGI cluster investigation that they performed in 2019. And finally, we'll review the CDC DGI Dear Colleague letter. So first, we'll walk through a clinical case study. So this is a 20-year-old woman who presents to emergency department with a rash on her arms, legs, trunk, and scalp that had just erupted that same morning. She also reports feeling generalized muscle aches, fever, and pain in both ankles. During the sexual history, she reports that 2 weeks earlier, she engaged in vaginal intercourse with a new male sex partner without barrier protection. She reports no other anatomic sites of exposure and denies vaginal discharge or pain on urination. On physical exam, you appreciate that she has erythematous pustules near the wrists and on the fingers shown in the picture, which are also visualized on her trunk, scalp, and both ankles. There is mild swelling and pain with passive motion in the right ankle and tenosynovitis involving the tendons of both ankles, but no appreciable joint effusions. So you have high suspicion that this is disseminated gonococcal infection. And to make the diagnosis of DGI, at what anatomic site should diagnostic tests be performed before starting treatment? So we're gonna do an audience poll for this one. And the possible responses include blood. So you'll send a couple sets of blood cultures, genital tract testing with a genital gnat or culture if available, the skin lesion, if there's a purulent exudate that you're able to send for culture, or all of the above. I'll give you about 10 seconds. A couple more seconds left. And great. You can see the result. So it looks like 79% of the audience got it correct, which I'll talk through briefly. So the answer is all of the above. Oh, there we go. Sorry about that. So blood cultures were collected before starting treatment in this case, and her blood cultures grew gram-negative diplococci that are shown here on the right that were identified as Neisseria gonorrhoeae to confirm the diagnosis of DGI. Her signs and symptoms rapidly improved and ultimately resolved with treatment. So this case really represents a classic textbook clinical presentation of DGI. And this constellation of signs and symptoms historically has been referred to arthritis dermatitis syndrome because of the polyarticular tenosynovitis and arthralgias associated with skin lesions. But confirming the diagnosis can be challenging since blood cultures are only positive in up to 50% of cases with this clinical presentation. So the key take home here is that it's important to obtain specimens from all disseminated sites of infection, so blood and skin in this case, if available, and also the exposed mucosal site or sites, which in this case was the genital tract. So now we'll transition to briefly review the gonorrhea epidemic in the United States. So as you are probably aware, STIs continue to rise in the United States with increases in gonorrhea, chlamydia, and syphilis. And per the 2018 CDC STD surveillance report, over 500,000 cases of gonorrhea were reported in the United States in 2018, with a 63% increase since 2014. Gonorrhea is caused by the bacterium Neisseria gonorrhoeae and is transmitted during vaginal, anal, and oral sex. And it can also be transmitted to the infant during delivery if the mother is infected. The clinical manifestations of uncomplicated gonorrhea include urethritis, presenting with urethral discharge and/or painful urination. However, it's important to remember that infections of the cervix, pharynx, and rectum are often asymptomatic. And if not detected and treated, gonococcal infections can lead to further complications shown here, including pelvic inflammatory disease, prostatitis and epididymitis, ectopic pregnancies, and infertility. Infants born to persons with untreated cervical gonorrhea at the time of delivery can develop hyperacute conjunctivitis and blindness. Gonococcal infections can become systemic, causing disseminated gonococcal infection, which is our focus today. And just a reminder that gonorrhea, and especially gonococcal rectal infections, increase the risk of HIV transmission and acquisition. This figure shows the United States rates of reported gonorrhea dating back to 1941. So current increases in gonorrhea can be seen in the context of historically high gonorrhea rates from the 1940s. However, with the advent of penicillin, there were drops in gonorrhea rates. That was followed by increases in the 1960s and early 1970s due to the changing demographics and sexual mores and better diagnostics. Then gonorrhea decreased again, but due to national screening, changing demographics, and also the HIV/AIDS epidemic in the United States. And since reaching a historic low in 2009, gonorrhea rates have been increasing. I want to call attention to this line graph showing rates of reported cases of gonorrhea in the United States by gender from 2009 to 2018. As was observed during 2014 and 2017, the rate of reported gonorrhea cases among males was higher than the rate among females, with both increasing during 2007 to 2018. And when looking from 2009 to 2018, this is an increase in rates among men by 135%. Looking at rates of reported gonorrhea in the United States by state and territory in 2018, there are certainly differences in rates, with the darker shades of blue representing the highest rates per 100,000 population. And you can see here that in 2018, California had a rate of 200 cases per 100,000 population. And as rates of gonorrhea are increasing, it's important to remember that gonorrhea antimicrobial resistance is also a growing threat. Since the dawn of the antibiotic era, Neisseria gonorrhea has developed resistance to each antimicrobial used for treatment. You can see here going back to the 1940s with sulfonamides and then penicillins, tetracyclines. And resistance is a concern because it undermines treatment success, increases the risk of complications, and can cripple control efforts by allowing continued transmission to partners. Following the emergence of fluoroquinolone resistance, CDC changed its treatment recommendations to only recommend treatment with cephalosporins. And in 2010, CDC changed recommendations to treat with dual therapy, azithromycin and ceftriaxone. And the ceftriaxone dose was increased. And just this past December 2020, the treatment recommendations for uncomplicated gonorrhea in adults and adolescents was updated. And the recommendation now is to treat with ceftriaxone alone at an increased dose of 500 milligrams as first-line therapy. Because of this development of antimicrobial resistance to multiple classes of antibiotics, in 2019, gonorrhea was designated as one of 5 urgent antibiotic-resistant threat level pathogens in the United States. So now with that background on what's happening with gonorrhea in the United States, we'll do a deep dive specifically into DGI. So DGI occurs when Neisseria gonorrhea invades the bloodstream and spreads to distant sites in the body. An infection leads to clinical manifestations like fever, particular pustular skin lesions, polyarthralgias, tenosynovitis, and septic arthritis, and on rare occasions can manifest as endocarditis, meningitis, and osteomyelitis. And clinical manifestations historically have been divided into 2 groups. The first being this triad of polyarthralgias, tenosynovitis, and skin lesions without purulent arthritis, also called the arthritis dermatitis syndrome, as I mentioned during the case study. And this has been historically described as the most common presentation of DGI, with polyarthralgias commonly involving the wrists, metacarpophalangeal joints, and ankles, which are usually asymmetric. And a distinguishing feature is the migratory nature of the arthralgias. Tenosynovitis is also relatively common and unique to DGI and unusual in other forms of infectious arthritis. The skin lesions have been reported to be common in up to 75% of cases and are typically described as pustular or vesicopustular, though can be hemorrhagic macules, papules, bullae, and nodules can rarely occur. Usually skin lesions are found on distal extremities and are rarely on the face. Fever, chills, and malaise may also be reported. And this group of clinical manifestations has also been referred to as the bacteremic stage, since bacteremia has been described in up to 50% of DGI cases presenting with this syndrome. Though it's important to recognize that it's not a continuous bacteremia, and most patients with DGI will have negative blood cultures. So here's the photo from our case patient, just as a reminder that although this patient had positive blood cultures, many patients presenting with these clinical manifestations will not. And it's important to obtain specimens, if possible, from other disseminated sites and mucosal sites of exposure. The other group of clinical manifestations is known as septic or purulent arthritis. And historically, this has been described in less than 50% of patients with DGI and typically presents as abrupt onset with pain and swelling in one or more joints. So it's considered monoarticular or oligoarticular septic arthritis. Most commonly involved joints include distal joints such as the knees, wrists, and ankles. And on rare occasions, direct extension of infected joint can result in osteomyelitis or infection of the bone. Most patients presenting with septic or purulent arthritis have not had preceding polyarthralgia, tenosynovitis, or skin lesions, though patients presenting with the arthritis dermatitis syndrome can develop septic arthritis later in disease course if it's not recognized or treated. And as I've alluded to, making the diagnosis of DGI can be challenging. If there's clinical suspicion for DGI, nucleic acid amplification tests, or NATs, and culture specimens from urogenital and extragenital mucosal sites as applicable should be collected and processed. In addition to culture specimens from disseminated sites of infection, for example, a pustular skin lesion, synovial fluid, blood, or cerebrospinal fluid, or CSF. However, cultures from disseminated sites of infection are often negative, and mucosal sites of infection, such as the urogenital, rectal, or pharyngeal, are often asymptomatic and not tested before empiric antimicrobial treatment is started, despite having a higher diagnostic yield. So as a result, DGI is usually a clinical diagnosis without microbiologic confirmation, which likely contributes to underdiagnosis and delays in treatment and reporting. Management of DGI cases should be guided by the CDC STD treatment guidelines shown here. Hospitalization and consultation with an infectious disease specialist are recommended for initial therapy, particularly for persons who may not adhere with treatment, have an uncertain diagnosis, or have purulent synovial infusions or other complications. Initial therapy should be antimicrobial treatment per the CDC treatment guidelines, which is currently IV ceftriaxone and azithromycin. The duration of treatment of DGI has not been systematically studied and should be determined in consultation with an infectious disease specialist. And given the emergence of antimicrobial resistant gonorrhea, as I mentioned, All Neisseria gonorrhea isolates in DGI cases should be tested for antimicrobial susceptibility, which does require culture and cannot be tested off of gnats. And I wanted to mention to be on the lookout for the 2021 CDC STI treatment guidelines, which are expected to be coming this spring and will have important updates on the treatment and management of gonococcal infections. DGI is estimated to account for a very small proportion of all gonococcal infections, approximately 0.5 to 3% of untreated gonococcal infections. However, the data on these estimates are older, from the 1970s, 1980s, and may not represent the true recurrent burden of DGI. Some of the challenges in estimating DGI burden of disease come from the challenge in making the diagnosis, as I previously highlighted. Historical risk factors for DGI have included female gender, recent menstruation, pregnancy, and having a terminal complement deficiency. Persons receiving eculizumab, a monoclonal antibody that inhibits terminal complement activation and is approved for diseases associated with dysregulation of complement activation, might also be at higher risk for DGI. There have been several DGI case reports among patients treated with eculizumab, as well as 8 cases per ongoing analysis of the FDA adverse event reporting system. And historically, there have been gonorrhea virulence factors and growth factors associated with serum resistance, meaning the organism's ability to resist the killing activity of antibodies in complement in normal human serum and increased propensity to cause DGI. And just one example is POR-B1, which is an outer membrane porin protein in Neisseria gonorrhea. And there are 2 alleles of the gene, including POR-B1A, which seems to be more common among DGI isolates compared to urogenital isolates. But that being said, there are urogenital isolates with POR-B1A, so it's not an absolute marker for DGI. DGI is suspected to result from a multifactorial process in which certain bacterial traits are probably necessary for DGI, but not sufficient. So there are strains that cause DGI in some people, but are found circulating among individuals with uncomplicated gonorrhea that don't go on to develop DGI. So the take-home message is that we still don't quite understand the full picture of DGI pathogenesis. And there have been questions in recent years about if we are seeing changing patterns of DGI, such as changing the demographics of those with DGI. And there have been limited population-based studies on DGI. However, a retrospective study that was published in 2012 reviewed records of women diagnosed with DGI that were admitted to a hospital in Dallas, Texas, over 34 years. And of the 112 women hospitalized for DGI during the study period, the frequency of DGI declined substantially over those 34 years in both non-pregnant and pregnant women, with the green bar graph in this figure showing the decline among pregnant women. And additionally, this figure demonstrates gonorrhea infection rates per 100,000 people, with the blue line illustrating a dramatic decline in uncomplicated gonorrhea in the US general population since the late 1970s, and the red line illustrating a similar decline occurring in women residing in the state of Texas. So this study suggested that the declines of DGI in women parallel a national trend of uncomplicated gonorrhea. The limitations to this study are that it may not be representative of the entire United States, and the study only reviewed cases among women. But there have been a couple of studies suggesting that DGI may be increasing among men, though these were outside the United States, one of which was a 3-year retrospective analysis of DGI cases in France, and this was between 2009 and 2011. They identified a total of and the number of cases increased between 2009 and 2011, though these are small numbers. Interestingly, when looking at cases by gender, 57% of cases were among men. When looking at cases by gender and gender of sex partners, almost half of men reported to be men who have sex with men, or 24% of total cases. An HIV co-infection was also reported in 2 cases, so nearly 10% of cases. So again, these are smaller numbers, but DGI may be more common among individuals living with HIV. But have reported DGI clinical manifestations been changing? When looking at the same study, 66% of all cases had joint involvement, with only 33% diagnosed with tenosynovitis and 19% with skin manifestations. And genital signs were reported in only 23%. So the study does highlight potentially a different pattern of DGI clinical manifestations, with higher proportion of cases with septic arthritis compared to the classic arthritis dermatitis triad. Though it is important to keep in mind that they only included cases with microbiologic confirmation, so it's missing those cases with negative cultures. So there may be a shift in demographics, behavioral factors, and predominant presenting clinical manifestations of DGI, though there remains a need for more population-based studies. But what about more recently in the United States? Do we have data from national surveillance to tell us more about patterns in DGI? As I mentioned, the historical estimates of DGI disease burden among those with gonococcal infections may not represent the current burden of DGI, and there are known limitations to current DGI surveillance in the United States. Cases of DGI are currently only reported as gonorrhea cases to CDC, and they can only be reported if there's a positive gonorrhea test. So this doesn't capture those with a clinical diagnosis without a positive laboratory test. For cases reported via the National Electronic Telecommunications System for Surveillance, known as NETS, cases of gonorrhea can only be reported with one anatomic site of infection. Though in the new STD message mapping guides, multiple anatomic sites of infection can be reported for gonorrhea. However, we know it will take time to get all jurisdictions onboarded with this. Additionally, there is no current way to indicate if a gonorrhea case is a disseminated infection. And when we do hear about cases, case reports are most often analyzed retrospectively or in clusters. So there's limited epidemiological data available on those cases. In recent years, we had heard anecdotal reports from healthcare providers around the country that they had been seeing more cases of DGI, and we wanted to develop a methodology for how to monitor DGI in the United States. So in 2017, the CDC Division of STD Prevention began a sentinel DGI surveillance project that has been conducted within the active bacterial core surveillance system known as ABCs, which is a core component of CDC's Emerging Infections Program. ABCs is a 10-site active laboratory and population-based surveillance system. And the DGI project within ABCs began in 2017, but conducted retrospective reviews on cases going back to 2015, starting with 2 jurisdictions, but has now expanded to 3 sites that send gonorrhea isolates that have been isolated from sterile sites in hospitals or labs to the CDC STD lab for AST and whole genome sequencing. Additionally, medical chart extractions are performed using ABC's DGI case report form. However, while this form is based on medical record abstraction and lab results, one of the limitations is that we are missing the critical behavioral data obtained from health department investigations. We do have preliminary analyses from the ABC's DGI project, which included 77 cases reported between 2015 and 2019. And these analyses revealed a predominance of DGI cases among males, with 64% of cases, of which 14% were among men who have sex with men. And of the clinical manifestations, which are not mutually exclusive here, 56% had documented bacteremia, 43% had septic arthritis, and 18% had a gonococcal mucosal site isolate. And 15.6% of cases had a reported HIV co-infection. Limitations of the ABC's DGI surveillance project are that ABC's DGI data likely underestimate the true burden of DGI since we currently exclude clinically identified cases, that is, cases without an isolate, but have been treated by clinicians for DGI. And furthermore, the surveillance area accounts for approximately 4% of the US population, so it may not be generalizable to the entire US. Analyses of these data are ongoing, though preliminary findings suggest similar changes in DGI epidemiology as these other studies have demonstrated. So now we'll transition to review the Michigan DGI cluster investigation. In August of 2019, we were notified by the Michigan Department of Health and Human Services about a DGI case cluster that was reported in Southwest Michigan counties. And the Michigan DGI cluster investigation was and is a joint investigation with the Michigan Department of Health and Human Services and Kalamazoo County Health Department. And to raise awareness, they put out a press release early in the investigation and a health alert for providers. They performed medical record reviews and reviewed DIS, patient interviews, of identified DGI cases as part of this cluster. And any available DGI case isolates were forwarded to the Michigan State Laboratory. They also reviewed 27,000 gonorrhea cases from the prior 18 months and the associated lab reports to look for specimen sources suggestive of DGI to identify additional cases. For the Michigan DGI investigation, confirmed cases were determined by isolation of gonorrhea from any sterile site, including blood, synovial fluid, or CSF. Probable cases were determined by a positive NAT from mucosal sites of infection in the presence of DGI clinical manifestations. And the cluster of cases was initially defined by overlap in place, time, and social history. From July to December, there were 17 total cases reported, 14 confirmed and 3 probable. the majority of which were in Kalamazoo County, shown here in the red, with 2 cases in bordering counties as shown here on the map in orange. When looking at the clinical characteristics, the majority of these cases presented with septic arthritis in 13 of the 17 cases, but notable other significant complications included myositis in 4 cases, osteomyelitis in 2, and a case of endocarditis that resulted in open heart surgery and required valve replacement. The majority of patients were hospitalized and required invasive surgery. Nearly all received the currently recommended therapy for DGI. And notably, 65% were diagnosed with mucosal gonococcal infections, though not all of them were tested at all sites, and some may have been negative because the test was performed after receiving antibiotics. Almost 60% of cases were male, with an age range of 16 to 67, with a median of 42 years. No immunocompromising conditions were known, and approximately 1/4 reporting housing instability. 81% reported or tested positive for drug use, with 63% reporting any methamphetamine use. No direct needle or sex contacts between cases were identified during this investigation. There were 12 DGI isolates available for AST and whole genome sequencing. Michigan performed AST by disc diffusion, with all isolates found to be susceptible to azithromycin, cefixime, and ceftriaxone. And whole genome sequencing was performed on all 12 isolates by Michigan. All 12 isolates were submitted to CDC for AST, which was performed by agar dilution and confirmed susceptibility to azithromycin, cefixime, and ceftriaxone. And all DGI sequences were shared with CDC for further bioinformatic analyses, as shown here. So in short, the red box is surrounding the sequences from the 12 DGI cluster isolates. An analysis revealed a highly related cluster of gonorrhea isolates associated with DGI cases in Kalamazoo and surrounding counties. The other isolates shown in this phylogenetic tree outside of the red box were selected non-DGI isolates from the same region as the cluster that Michigan had available to be able to show that these are distinct compared to others in the region. And in response to the Michigan cluster, on December 5th, 2019, the CDC STD Division Director, Dr. Gail Bolin, sent out the CDC DGI Dear Colleague letter to STD programs and public health laboratory directors to raise awareness about DGI in the ongoing Michigan cluster, and also to provide recommendations to the state and local STD program staff and laboratories, including to consider investigating DGI cases and conducting partner services, to report confirmed DGI cases via routine case notification, to notify medical providers and laboratory staff, and to submit available DGI culture isolates to CDC for additional testing, and to share additional DGI tools and resources. To better understand the magnitude of DGI in the United States and if other clusters are occurring, CDC requested that health departments consider investigating any DGI case, including confirmed, probable, and suspect cases, to ascertain the key demographic, epidemiologic, and clinical factors associated with the case. And also to conduct partner services to obtain behavioral risk factors that may not be otherwise captured, and to ensure partner testing and treatment. As part of partner testing, to consider obtaining a gonorrhea NAT and culture at all sites of sexual exposure as local capacity permits. And in the setting of a DGI cluster, consider cluster investigation strategies based on available staffing and resources. Currently, there is no CSTE case definition for DGI, and DGI cases are reported to CDC as part of routine surveillance for gonococcal infections. However, we provided a working DGI case definition along with the DGI Dear Colleague letter that included the following laboratory criteria: the isolation or detection of Neisseria gonorrhoeae, either from a disseminated site of infection by culture or from a mucosal site by culture or NAT. And for the case classification, a suspect DGI case is defined as, in the absence of a more likely diagnosis, clinical suspicion of DGI without meeting any of the laboratory criteria as defined on the previous slide. Probable DGI case is defined as clinical manifestations of DGI and isolation or detection of Neisseria gonorrhoeae from a mucosal site. And a confirmed DGI case is defined as the isolation of Neisseria gonorrhoeae from a disseminated site of infection. On October 20th, 2020, the new CDC DGI case report form shown here became available online that can be used to collect the critical data elements we need at CDC to better understand and characterize DGI cases nationally. And this includes information such as the case report information, demographics, the DGI clinical presentation, clinical course and outcome, the patient's past medical history, and behavioral data and partner information. Completion of the form may require both clinical and epidemiologic staff collaborations, as these are data that may need to be abstracted from medical chart review NDIS interview records. The form can be completed and submitted to CDC via a secure REDCap survey. Health departments are encouraged to continue to report confirmed DGI cases to CDC via routine case notification mechanisms. If reporting via nets, to prioritize the sterile site as the reported specimen source when reporting the case, if there are positive laboratory results from multiple anatomic sites. And we continue to encourage state and local health departments to raise awareness about DGI among medical providers, as clinicians are crucial to helping us better understand the magnitude of DGI in the United States and also identify if clusters of DGI are occurring. Specifically, it's important that clinicians report any laboratory confirmed or clinically suspected cases of DGI to the state health department STD program as per state or local reporting requirements. Obtain both the NAT and culture specimens at all exposed anatomic sites for patients with suspected DGI. This is particularly important that these specimens are obtained before starting antimicrobial treatment for patients with clinical findings suggestive of DGI. And then to ensure that gonococcal DGI isolates from disseminated sites and or mucosal sites are submitted to local or state labs and can be forwarded to CDC for comprehensive AST and whole genome sequencing. Available resources include the DGI Health Alert template that's available on our website for state or local use as needed. Also, the STD Prevention Training Center Clinical Consultation Network is a great resource for clinicians and STD program staff to request consultation from STD experts on complex or challenging cases. And the CDC STD treatment guidelines, which as I mentioned, will be updated in spring 2021, so please stay tuned for this. So in summary, as rates of gonorrhea continue to increase in the United States, we may see parallel increases in rare clinical presentations such as DGI, and there may be changing epidemiology of DGI, which clinicians and public health staff should be aware of. Michigan continues to investigate a DGI cluster in Kalamazoo and surrounding counties. While no epidemiologic links have been identified through case investigations, results of molecular sequencing suggest a highly related cluster of gonorrhea isolates associated with DGI isolates. With cases. And to help us better understand the magnitude of DGI in the United States and if other clusters are occurring, clinicians should report any DGI case to their health department per local protocols, obtain NAT and culture specimens at all exposed anatomic sites, and also ensure Neisseria gonorrhea isolates are submitted to state or local health labs. And health departments can investigate and conduct partner services as resources allow for DGI cases and submit available DGI isolates to the CDC STD lab for additional testing. I just want to acknowledge my colleagues in Michigan at the Kalamazoo County, Calhoun County, and St. Joseph County, and also my colleagues within the CDC Division of STD Prevention. Thank you. So now we'll transition to Dr. Tang.
Thanks, Dr. Quilter, for that wonderful overview. It's a great transition information to my presentation and my part of the webinar. So I'm going to go ahead and share my slides. All right, can everyone see them? Sorry, one second. All right. So I'm going to be talking about the increases in disseminated gonococcal infection in California. I'll be referring to disseminated gonococcal infection as DGI, and then I may use GC on occasion to as an abbreviation for gonorrhea. So I'm going to be talking about very briefly on the gonorrhea epidemic in California. I'm going to focus most of my time on the California DGI cluster investigation and what you as clinicians can do. But at the end, I'll go over some resources that you can use and review after the presentation. So first of all, some California gonorrhea epidemiology. So similar to the United States as a whole, the burden of notifiable bacterial STDs in California continue to be substantial and have been increasing significantly over the past 5 to 10 years. For the focus of this talk, gonorrhea, there were almost 80,000 cases of gonorrhea in 2018, with the rate of gonorrhea reaching nearly 200 cases per 100,000 population. The This represents a 5% increase in cases over 2017 and 77% increase since 2014. The rate of gonorrhea in California in 2018 was higher than the US average of 179 cases per 100,000 population. This map of California illustrates the incidence rates of gonorrhea by county in 2018. The darker the color, the higher the rates. There were 10 counties with gonorrhea rates higher than the state's overall rate of 199.4 per 100,000 population. These 10 counties were San Francisco, Los Angeles, Lake, Kern, Sacramento, Del Norte, Delano, Alameda, Fresno, and Yuba. Next, I'll talk about our DGI cluster investigation and how we started to notice an increase in cases in California. So as Laura mentioned, the CDC released a Dear Colleague letter reporting an increase in DGI cases in Michigan. The California Department of Public Health received this Dear Colleague letter, posted it on our website, and shared it with our local health departments and STD controllers, asking them to disseminate this information to healthcare providers in their counties and to report DGI cases in the state, to the state STD control branch. As with many communicable diseases, gonorrhea is a notifiable disease, and providers and labs are required to report gonorrhea per Title 17 California Code of Regulations. For all but 2 counties, this information is reported in the state surveillance system called CalReady. DGI cases are reported to CDPH as gonorrhea cases, but GC can be reported by specimen source, body site, and symptoms. For form or CMR, providers can indicate specimen source and presence of symptoms. When labs report gonorrhea cases, most of them include information on specimen source or specimen body site and type of test. So we use the working case definition of DGI, essentially identical to the one used in Michigan. We considered a case to be confirmed a DGI if gonorrhea was isolated by culture from a disseminated set of infections such as skin, synovial fluid, blood, or CSF. If gonorrhea was not isolated from a disseminated set of infections, but was isolated or detected from a mucosal site of culture, site by culture or NAT, and had clinical manifestations of DGI reported by the provider, the case would be considered probable. Suspect cases were when there was no laboratory evidence of GC infection, but a clinical suspicion of DGI. So after disseminating the CDC Dear Colleague letter on DGI in December of 2019, we started to review a trickle of cases reported to the state by local health departments in early 2020. However, COVID-19 hit, and many staff, including myself, were redirected to work on COVID-19 response efforts, but we were still passively receiving reports of possible DGI cases. Many months later, an infectious disease physician called their local health department in September of 2020 and later reached out to the state public health department in October. By October 28, 2020, they had noted at least 6 cases of DGI at their hospital over the past few months. They also heard from another ID doc in a neighboring county about an uptick of DGI cases at their hospital. CDPH reached out to local health departments to review possible DGI cases in 2 counties as well as neighboring counties. We pulled possible DGI cases in Calgary with suspicious sites of infection, and our clinical team reviewed DGI cases reported by providers and electronic lab reporting. So we noted a cluster of DGI cases in 4 adjacent counties starting around July 2020. They included Kern, Los Angeles, Santa Barbara, and Ventura counties. Cases that were included in this cluster were those that occurred in these 4 counties and that had occurred since July 2020. Since July 2020 through January 2020, we noted 29 DGI cases, 21 which were confirmed and 8 that were probable. Here's an epi curve of the cluster of DGI cases in the 4 cluster counties by month from July 2020 to January 2021. Our preliminary data shows that 29 cases were distributed over 7 months, with a peak occurring in October 2020. We wanted to determine if this was an increase in cases in these counties was in fact above baseline. Thus, we reviewed all possible cases reported in our state surveillance system from all of 2019 and 2020 and created this epi curve over time by month. We noted 9 total cases in 2019 compared to 25 cases in 2020, almost 3 times the number of cases noted in the year prior for this region. Even if looking at only confirmed cases of DGI, there were 2 times the number of DGI cases in 2020 compared to 2019. There appears to be a possible decrease in cases in more recent months in this region, but this may be due to reporting delay and is something we continue to monitor. When summarizing the characteristics of this cluster of DGI cases, we noted a median age of 27 and median age 37 and a mean age of 39. Most cases were between age 26 to 45, so patients were as young as 18 and as old as 68. Hispanic and Latinx ethnicity were disproportionately represented in the cluster, which is identified in 52% of cases. Similar to historical data, the majority of cases were among cisgender females. When gender of partners were known, all of them reported opposite gender sex partners. So the cluster appeared to be among heterosexual individuals and networks. While homelessness is a difficult variable to track among cases, we did note a relatively high percentage experiencing homelessness, almost 20%. And when you are only including those whose housing status is known, 29.4% or almost a third of cases were experiencing homelessness. Illicit drug use was noted in over a third of cases, particularly methamphetamine use. And we're still looking at IV drug use, but unlike the Michigan cluster, we did not notice IV drug use as a common risk factor. And most of those who reported meth use did not report IV drug use. We were also interested in history of incarceration, though that has also been difficult variable to verify. However, we did know at least 2 cases in the cluster with a history of recent incarceration. So as I mentioned earlier, there's 21 of the 29 cases that were confirmed, 8 were probable cases. Positive synovial fluid was the predominant way in which cases were confirmed, with 1 case having both a positive blood and synovial fluid culture. Most cases had gonorrhea detected at a urogeneral site, although both pharyngeal and rectal gonorrhea were also detected. The substantial higher number of detection at the urogeneral site may at least partially be due to providers only testing at the urogeneral site. In terms of symptoms, joint involvement was most common, and fever was noted in about 40% of cases. We're still reviewing the percent of cases with rash and skin findings or genitourinary symptoms, though qualitatively seem to be rather uncommon in this cluster. 1 case did have endocarditis and embolic strokes. Also, 1 person had co-infection with COVID and presented only with constitutional symptoms and no joint pain. Other clinical characteristics of interest not shown here include comorbidity. We're still reviewing cases, but at least 2 had co-infection with HIV. In addition, a few cases did have susceptibility to testing results. At least 1 case was resistant to ciprofloxacin, and another had decreased citrulline resistance to tetracyclines. But fortunately, all of the septic testing results that we have reviewed to date, they have all been susceptible to cefixime and ceftriaxone. So due to this increase in cases, CDPH released a letter to the local health departments on November 5th, 2020, notifying providers of increased reports of DGI in California. In our letter, we shared that many of the patients reported experiencing homelessness and or illicit drug use, particularly methamphetamine use. So we discussed this with many of our public health partners, including a meeting that the local health officers associations, communicable disease, ST controllers, also presented this at the National Coalition of ST Directors and encouraged all to disseminate this information widely. So CDPH ended up releasing a press release of the news of this news on November 20th. And this was picked up by local news outlets, including the Sacramento Bee and the San Francisco News. We ended up releasing another Dear Colleague letter specific for clinicians on December 23rd, 2020, and reached out to the California Medical Board for distribution, as well as many other California medical specialty organizations that included family physicians, nurses, orthopedic surgeons, rheumatologists, primary care physicians, sports medicine docs, podiatrists, and some of our friends at Planned Parenthood and public health and commercial laboratories. We also recently sent out a notification to hospital infection preventionists. So in partnership with the California Prevention and Training Center, we created a DGI FAQ document for medical providers, as well as a flyer and card templates for patients that could be adopted by clinics. So this is a map of a DGI case in California by a region in 2020. So we ended up reviewing possible DGI cases in 2020 across all of California. The counties that are highlighted on the map are counties in which there was at least one DGI case in 2020. This is an epi curve of the verified DGI cases in California in our state surveillance system for year 2020, organized by month. So you can see that overall there appears to be an increase in cases from the second half of 2020. So what can clinicians do? We have a list of 6 specific recommendations for providers in California. So 1, providers should instate routine screenings for STDs. The CDC and CDPH currently recommend that all sexually active females aged less than 25 be screened for chlamydia and gonorrhea. And those 25 or older who have increased risk factors should also be screened. For MSM or menopause men, they should be screened at least annually and more frequently if at risk. Screening includes regular testing of all exposed sites based off reported behavior regardless of condom use. For men only reporting sex with women, no routine screening recommended, although screening in high prevalence settings such as STD clinics, correctional facilities, or if your facility or county has a high rate of gonorrhea, is also reasonable to screen men, tested women as well. For HIV positive individuals, screening at least annually is recommended and includes exposed extragenital sites. Patients on HIV PrEP should also be screened every 3 months. And those who have a gonorrhea infection should be retested 3 months after treatment, not for test of cure, but for the increased likelihood of reinfection. In addition, given the high portion of DGI cases noted to experience homelessness or reporting illicit drug use, particularly methamphetamine use, it's reasonable to consider screening these individuals as well. So in terms of the second recommendation, providers should increase their clinical suspicion for DGI in patients with joint pain. In many cases, patients had initially presented with joint pain attributed to another cause, which delayed the diagnosis and only was later determined to be due to DGI. Sometimes they even received oral or even injected steroids into a joint due to a presumption it was osteoarthritis or gout, worsening the clinical outcome. Therefore, it's important to include DGI in differential diagnosis. Explore the nature of the joint pain. For example, was it migratory? Ask about rash, conduct a good skin exam, paying particular attention to the distal extremity. Ask about urogenital symptoms or even rectal and pharyngeal symptoms, although gonorrhea often is asymptomatic at these sites and often asymmetric even at the urogenital site for DGI cases. Make sure that you take a social history that includes a sexual history and drug use history, as well as housing status for patients reporting joint pain. And ensure that you aspirate a joint if there is an effusion present. So if there is a clinical suspicion for DGI, NAT and culture specimens, if available, from urogenital and extragenital sites, for example, pharyngeal and rectal mucosal sites, as applicable, should be collected and processed in addition to NAT, and just to culture specimens from disseminated sites of infection. Ideally, obtaining these specimens before initiating empiric antibiotic treatment, though understandably that this may not always be possible. Hospitalization is recommended as a consultation with an IV specialist. If specialist is not available, providers can always use the STD clinical consultation network to submit an electronic request for consultation. While it's not a hotline and not to be used for immediate consultation, one can receive a response as soon as 1 business day. I quickly wanted to note that NATs are not only recommended for urogenital screening, but also for extragenital sites. NAT for rectal and pharyngeal specimens was recently approved in May 2019 by the FDA for 2 diagnostic tests, Optimal Combo 2 assay from Hologic and the Expert CT NG from Cepheid. However, many other public and commercial labs have gone through the process of validating their own swabs for external testing, including for self-collection. However, susceptibility testing results requires culture, and thus any gonorrhea cultures that are positive should be sent for resistance testing. Please contact your local health department for guidance on obtaining culture if not available at your site. As mentioned, some public health and commercial labs may be able to provide gonorrhea culture. Some can also still do antimicrobial susceptibility testing. One large commercial lab that's available in many parts of the state include Quest Diagnostics, and Mayo Clinic and the CDC also perform susceptibility testing for gonorrhea. The state lab is working on this, and we're hoping to provide this susceptibility testing later this year. So This recommendation is for providers to report all lab confirmed and clinically suspected cases of DGI to local health departments within 24 hours of identification. When reporting suspected and confirmed cases of DGI to your local health department, you are going to want to provide information on signs and symptoms, including date of onset, and also include the socio-demographic information as well, including someone who's experiencing homelessness or using drugs. While this is a mandatory requirement by Title 17 of California Code of Regulations, it is something that gives an opportunity for the public health department to assist you in reaching the patient and their partners. The public health department can provide information on DGI, on the DGI history or history of STDs in the past, help find patients who are lost to follow-up. They can notify partners anonymously and get them tested and treated, and also provide access to treatment for DGI gonorrhea. And of note, when they're reported, the provider and or patient may receive a call from public health for investigation of these cases. So this is a generic confidential mobility report with Orange County as the example for information on where to report. Each local health department has its own address and contact information. So you'll want to provide the patient's contact information as well as some demographic and clinical information. Unfortunately, the generic form is fairly basic for GC reporting. Providers can provide specimen source as well as symptoms, whether symptoms are present, and there's also an additional area for remarks that they can include. Laura showed this form, the CDC DGI case report form. It was created really for local and state health departments to send information to the state or CDC, but it also can be used for providers to report to the local health department. It has a lot of great questions that and variables that we're looking at, and you can find that form at the link on the slide, and reach out to your local health department for further questions on DGI and reporting requirements that they might have. The sixth recommendation is lastly that CDC and CDPH is interested in receiving all clinical isolates from DGI cases, so please save them. Work with your laboratory facility to ensure all available isolates from DGI cases are sent to the local public health lab and not discarded. And they should send these to the local health department so that they can submit them to CDC and CDPH. The state or CDC will perform whole genome sequencing to identify phylogenetic analyses to determine if these cases are genetically related. And CDC also has the ability to do antimicrobial facility testing, as I mentioned before. We are still waiting for the results of this phylogenetic analysis, so we're hoping to receive them in the next 2 weeks. So DGI treatments. So just doing one time check. I will probably not, this is the audience poll, and just because of time, I may skip it, but why don't we, I'll ask the question, you guys can think about it. What is the recommended treatment regimen for DGI arthritis and arthritis dermatitis syndrome? So is it A, ceftriaxone, 60 milligrams every 24 hours, or azithromycin 1 gram PO, ceftriaxone 500 milligrams every 24 hours, ceftriaxone? Well, I guess we can just do the poll. I think it's up while I read the answers. So go ahead and enter your answers. Ceftriaxone 1 gram Q 24 hours with azithromycin 1 gram PO, ceftriaxone 1 gram IM every 24 hours, ceftriaxone 1 to 2 grams IV Q12 24 hours, and azithromycin 1 gram PO. So why don't we close the poll? Okay. So it looks like about a third of people chose C. That is the correct answer, and 16% chose D. Sure. So I'm going to close the poll. So the answer is D, and that is the current recommendation in the 2015 STD treatment guidelines by the CDC. So A and B are incorrect because the ceftriaxone dose is too low. D, currently, as I mentioned, azithromycin is included in the 2015 recommendation, although of note, it's likely to be dropped in the 2021 CDC STI treatment guidelines. So we'll see if that's official once those are released. And then E, that is actually a recommended treatment for DGI endocarditis or meningitis. So this is a treatment for arthritis and arthritis dermatitis syndrome. Mentioned the ceftriaxone 1 gram IM and IV every 24 hours. Azithromycin is currently recommended in the 2015 guidelines. You can also use alternative regimens of cefotaxime or ceftazine if ceftriaxone for some reason not available. And then when you're treating for this, you can switch to an oral agent guided by antimicrobial susceptibility testing after 24 to 48 hours with substantial clinical improvement, and total treatment should be at least for 7 days. For the GC meningitis and endocarditis, you want to use ceftriaxone 1 to 2 grams IV every 12 to 24 hours. And therapy for meningitis should be at least 10 to 14 days, and endocarditis should be for at least 4 weeks. So additional management considerations, just this is for gonorrhea or DGI, and once you diagnose them with gonorrhea, it's really important to test them for HPV, syphilis, and chlamydia. We've seen that sometimes providers have forgotten to test for these other STDs as well, and then offer HIV pre-exposure prophylaxis. Indications for PrEP include MSM with gonorrhea, chlamydia, or syphilis that they're diagnosed or reported in the past 6 months. Or any woman or man with a bacterial STD like gonorrhea or syphilis diagnosed or reported in the past 6 months. It's important to treat partners, recent sex partners in the past 60 days preceding onset of symptoms should be referred for evaluation, testing, and presumptive treatment. Many both patients and partners have asymptomatic infections, at least at the mucosal site, and you'll want to test GC and CT at all sites of exposure. To avoid reinfection, sex partners should abstain from unprotected sex for 7 days after they and their sexual partners have completed treatment and after resolution of symptoms is present. So these are the updated gonorrhea treatment recommendations that the CDC released in December 2020. And they're no longer recommending treatment with dual therapy, only recommending monotherapy with ceftriaxone at a higher dose. And reasons are in the details of the MMWR, but primarily due to the need for antibiotic stewardship and an increase in GC isolate with decreased stability of azithromycin is kind of the main reason for switching to monotherapy with ceftriaxone. However, if chlamydia is not excluded, doxycycline 100 milligrams BID for 7 days is recommended, although you want to avoid that in pregnancy and use azithromycin instead. Also, I want to mention that patient-delivered partner therapy, also known as expedited partner therapy or EPT, is something that is permissible in law. It's essentially treating sex partners, a person to receive an STI diagnosis by providing medications or prescriptions to the patient. And ideally, you would have the partner come in and be treated with ceftriaxone, but you can use ceftriaxone for gonorrhea. It's actually an increased dose from what was previously recommended, from 400 to 800 milligrams times 1, and more details are in the MWR. If someone is uncomfortable reporting or telling their partner about their STD infection, they can always do it anonymously through the tellyourpartner.org, the internet-based anonymous identification, so partners can let them know via text or email. And I'm having a delay. I'm having problems with my slides. 1 second. There you go. And then finally, just wanted to go over the take-home points. So, DGI is increasing in California. You want to increase your clinical suspicion for DGI for patients with joint pain. Make sure you obtain NAT and culture specimens at all exposed anatomic sites, including pharyngeal and rectal, for patients with suspected DGI. Report DGI cases to your local health department, treat partners, and if needed, do it by partner-delivered partner therapy. Ensure gonorrhea isolates from DGI are sent to public health lab, and reinstate routine STD screening and include screening those who are homeless, as well as those who use illicit drugs, particularly methamphetamine. So here are some resources that I mentioned before, and then you can go to our website, which has additional resources, including the Dear Colleague letter, as well as the up-to-date CDC treatment guidelines. 1 second, having problems. There we go, dancing. And then there's also additional clinical guidelines and electronic consultation with the STD CCN. There's also an app from the CDC that you can use. these are additional resources, and want to thank you for your attention, and acknowledgements to all the staff at the local health departments, state departments, and our neighboring colleagues in other states as well, the CDC, who have really helped with our DGI investigations and providing information for this presentation. Thank you.
All right. Excellent, excellent. Thank you so much, Dr. Tang and Dr. Quilter. We have about 10 minutes left, and there's a couple questions. So one question that came up that I think is a good one to start with is, are fluids from lesions infectious in terms of skin to skin without sexual contact? So if you have a patient who has these pustules, could that infect other people?
I would say, I think the two parts to that question. One, I was going to say that, you know, the skin to skin, there would not be possibility of transmission, but I guess the question of skin to a mucosal site, where there can be, you know, infection with gonorrhea, you know, I have not been aware of that kind of transmission. I would say low risk, and kind of thinking through the pathogenesis of how these skin lesions come to be. And so really historically, the understanding has been that these occur because of the bacteremia. So you have the Neisseria gonorrhea in the bloodstream, and actually seeds the skin. So it's not coming with direct inoculation from someone else with gonorrhea, but it's actually seeding from the bacteremia. And as I mentioned, this is thought to be not a continuous bacteremia. And because of that, typically we think of it as being a low bacterial load, which is actually why it's really, we think why it's really hard to culture sometimes from disseminated site of infections. And honestly, it's, you know, culturing from skin can be very low yield, at least from studies they've done. So I think based on that, with the low bacterial burden, I would think would be very low chances of, you know, an open skin lesion. So it has to be open, you know, draining, then being exposed to a mucosal site and leading to a gonococcal infection in the partner.
Yeah, so Dr. Quilter, it sounds like in general, there could be gonorrhea bacteria in those lesions. However, it's probably a small amount. And in general, bacteria likes to infect the columnar cells that are lining the mouth and lining the vagina and the rectum and the urethra. And so usually, even if the bacteria did come in contact with skin from someone else, it probably wouldn't infect the skin. Does that sound okay?
Perfect.
All right, great. All right, another question, which I think is a good question for Dr. Tang, is where can we get access to the flyers that were created for patients? So is that available specifically at the CDPH website? Should people reach out to their local health jurisdictions in California?
Yeah, that's a great question. We don't have them on our website. They're not CDPH branded, but if you reach out to me, also if you got the handout, there is an email address under the example flyer that has Lizette Alvarado's email address. She is our DGI coordinator, and you can also reach out to her and she can send it to you.
All right, okay, the questions are coming in. We have 7 minutes to answer 17 questions. So we'll just go through them. I think we can do it. So first, just to review really quickly, I can answer this one. Is monotherapy okay for uncomplicated gonorrhea? And also, is the treatment dose 500 milligrams IM ceftriaxone, not 250? So that was, thank you, Melissa, for bringing that up. The CDC did release new treatment guidelines for uncomplicated gonorrhea, and it is monotherapy with only ceftriaxone, 500 milligrams IM on its own without the azithromycin. So that is the first line regimen, and you can find that on CDC's website. And so the next thing that came up was, if our clinic is not able to aspirate a joint effusion, where can we send them for that? And so that's a question, I think, for our California people. Dr. Tang, would you recommend clinics sending their patients to the local health department or contacting them through that? Or is there a different way that you would recommend?
Yeah, I think it's going to depend on the local health department and the county, but the emergency department will have the ability to aspirate the joint. So that is one option if a patient can get care there. There may be other clinics or partners in the area that can do that, but I would say probably universally, at least the ED would be able to do that.
Okay, great. Yeah. So I think yeah, that would be something. If you have a patient and you can't do it yourself, then you can coordinate with your local health department for where to do that. All right.
Yep. Add to if you're able to do the mucosal site testing and the blood cultures, to do that while you can.
Okay, perfect. All right. This is a good question. What is the regimen for DGI? I hope you guys are ready for this. If the patient is severely allergic to ceftriaxone.
Do you want me to go first, Eric?
Severely, as in, I'm assuming, and this is an anonymous attendee, so we're asking for a friend. This would be someone who has an anaphylactic ceftriaxone type 1.
I mean, I think this is, as I mentioned, that DGI case is particularly for initial therapy to consider consultation with infectious disease specialists. So this is definitely a scenario where you want to get someone on board. And I recognize there may not be ID specialists everywhere. So certainly contacting, whether it's through the PTC or trying to get, I think, expert consultation on this. Okay. My first thought is, we do have recommendations for the alternative therapy for gonorrhea in situations where you have severe ceftriaxone allergies and can't use that. And that's the recommendation with gentamicin, azithromycin. And I think just depending on the extent of the allergy, what they've tolerated previously, sometimes getting a really extensive allergy history can be really helpful at kind of recognizing additional therapies. And I think it's really important also because, there may be people who have uncomplicated, I guess I'll say uncomplicated DGI where, they have the fevers, chills, rash, versus those, I mentioned some of the cases in Michigan that required, the infection in the joint was so severe that it actually had started eating muscle and required debridements and in the hospital for weeks. And so, there's certain cases where they may be on therapy for weeks, and it's very important to make sure you get consultations to make sure they're on the most appropriate therapy.
Great. Excellent. All right. Thank you so much, Dr. Quilter. We have two more interesting questions. One is, how long does joint pain or similar symptoms usually last after treatment? So in other words, once you do treat, how long does it take for them to feel better?
So historically, people respond really quickly to treatment. Like I mentioned, I think folks who have much more extensive cases requiring debridements, obviously it's probably going to take a little longer to rebound. But I think folks with the polyarthralgias, tenosynovitis, my understanding has been typically rebound within days to less than a week.
Okay, excellent. Let's see. I know I've been asking Dr. Quilter a ton of questions. Dr. Tang, if you want to do this one, it's a good one. What role, if any, does Truvada play in the increase in GC, which I think is, I'm assuming this is another anonymous asking for a friend. I'm assuming by Truvada, they mean pre-exposure prophylaxis and not the drug Truvada itself. So what are your thoughts on that? What do you think is the relationship between PrEP and the overall increase we've been seeing in gonorrhea in California?
Yeah, that's a really great and controversial question, and I think it's a lot of different layers to it. I think there's been a lot of attention on PrEP and whether, that is increasing true rates of other STDs as people report not using condoms as much, potentially having more partners. I think people like to blame one thing, and I don't think it's really just PrEP. There's a lot of things going on, but one thing to note, at least with people on Truvada and taking PrEP, the recommendation is for them to get tested for STDs every 3 months. And so people are getting tested more, and when you test more, there's going to be more that's reported to us, and that can partially explain the increase. Not to say that people aren't just getting more infected, truly getting more infection because they are in PrEP. But, we think, sometimes that someone on Truvada is considered, high risk for STDs. They're getting tested every 3 months, which is great. because they're the ones that we do want to test more frequently. So it's not something we want to blame Truvada or PrEP on, but this is, I think PrEP can also be a really great tool to help detect and treat more STD infections.
Fantastic. Okay, we are at 1:15, and I think that that's our time. We have a couple more questions, so I will do my best to try and answer these individually, and then you can also please, if you don't get an answer to your question, then you can always email either elizabeth.olson@ucsf.edu, or you can email, I think our speakers provided their email addresses, but if you don't have that, then please email elizabeth.olson@ucsf.edu. And we can forward the questions on to whichever speaker you would like us to and connect you that way. Thank you everybody so much for your time. Thank you especially to Dorothy Wang and Elizabeth Olson and Lauren Blackley, and our esteemed speakers, Dr. Tang and Dr. Quilter. And I hope everyone has a nice rest of your day. Bye.